Okay. Um, I think it would be great to get started. And I think there's a few more people who might roll in as we go the next few minutes. But thank you guys for coming. And I'd like to introduce Dr. Laurent Martin. Most of you know him anyway, but he's a staple in our department and an associate professor with both the pharmacology department, but also in anesthesiology. And he's been doing some really cool research with green light therapy with rodents. Uh, and it's just a lot cooler than what a lot of us are doing. So it's more fun to hear about. And yeah, excited to hear about your research.
Thank you so much, Sophia, for the kind introduction. So I don't know if it's cooler. I think that all projects are kind of really cool. Even, I mean, when we're in the pharmacology seminars, all the projects are actually very nice. So, but I think it's going to be a bit funny because first, I'm delighted to present at this Tucson Drug Club, but I'm not going to talk about drugs. So today it will be mostly about non-pharmacological approaches to treat chronic pain. But okay, is this working? Yes, but first, before describing a bit what we do in the lab and all our project and everything, I really want to start to talk about the patients. Because I remember when I arrived in Arizona, so a few years ago, as a young postdoc, I knew nothing about pain. I knew nothing about chronic pain. I did my PhD on Alzheimer's disease, and then I switched to that. And I remember attending a conference where a patient, a chronic pain patient, shared with us his 40 years journey of chronic pain. And I was really surprised because for me, the goal was to find a new molecule, test it, that will solve pain, and boom, we're done. No, patients are actually looking for something else. And one thing that is very important is also validation. For, for chronic pain patients, having physicians acknowledging their pain and finding an explanation for it is almost as important as pain relief. And so the bigger picture is not only about pain. So, of course, a lot of patients are seeking pain reduction, but they also want to take part in their family activities, also to be able to perform chores, to better sleep, to be able to work. So, the picture is much more complicated than what we think. And I think it's very important that we keep that in mind. And we also have a lot of room to improve all our approaches because there is a very strong dissatisfaction with opioids. Because first, it's kind of short-term relief for pain, and also it comes with a plethora of side effects. And there is also this concept of that I like of, especially in fibromyalgia, this concept of walking chemists. It's patients who are taking so many different medications, but they do not find pain relief. And of course, patients really want to avoid, especially with everything that we saw happening in the past, physical dependence. But the picture is even trickier than that because all the patients are different. And there is a very strong heterogeneity in the responses to different treatments. As an example, with this clinical trial for diabetic neuropathy, with using capsaicin patches over 12 weeks, we can clearly see that patients responded in a very different way to the treatment. Even in a small proportion of the patients, the pain worsened. The pain actually increased after the patches. For around 30% of the patients, there was absolutely no changes in their pain score. For about also 30% of the patient, there was an improvement in their pain score, but then a loss of efficacy. And then the last remaining 30%, they indeed experience sustained improvement of their pain. So all patients are different. They do not answer the same way to a treatment. And it's not only about capsaicin. There is this, it's actually with all the different drugs. But just to illustrate it, it's another meta-analysis of the use of fentanyl. So which is fentanyl, one of the strongest opioid. So here it was used in cancer pain. And here you have plotted. So one dot equals one patient in four different clinical trials. And basically, it's the difference between the effect of the treatment versus placebo. So if you are on the zero here on the line, it means that there was no analgesia. If you are under the line in the negative part, it even means that the placebo was stronger than the than the treatment. And here at the top, it's the patient that experienced good analgesia. So you can see that there was, for some patients, even fentanyl did not provide anything, so cancer patients, whereas some others had a good pain relief. And there are all these patients in between. So even for fentanyl, one of the strongest opioids, we have very different pain relief between patients. And this is I think, a very important concept for us who are doing research. So there is this very strong heterogeneity, all the side effects, and we have to find solutions for that. And the patient's needs are sometimes a bit different from what we are researching for, all our research and everything, developing a new compound, all that. And patients are often asking for a holistic approach. They don't want to have only pain relief. They also want their anxiety to be better, their sleep. So we need to find approaches that will be able to cover all that. Also, there is more and more over the past 10 years, a very strong demand for non-pharmacological approaches. And I cannot emphasize it enough, support for patients, because it's fun. We are all working with therapies, either non-pharmacological or pharmacological, but also support to the chronic pain patient is very important, whether it's emotional or letting them understand what they are actually experiencing. Why are they in chronic pain? This question is sometimes very difficult to answer, but there's also this whole aspect that is very important in healthcare. And so I'm mentioning all that just so everybody's aware that we need to expand the available therapeutic options, depending on the patient demand, on the heterogeneity, all the side effects. So we need to develop that. And here in our lab, we started to open a new door about photoneuromodulation. So what is exactly photoneuromodulation? So in the retina, so in the eye, you have photoreceptors. So when light is emitted, it will activate these photoreceptors in the retina. And then so you will have a neuronal signaling that will reach the brain, especially the visual areas. That's how we see. But also areas involved in the regulation of sleep rhythm and our circadian rhythm. And what has been discovered over the past 40 years is that these neurons in the retina also connect areas involved in pain modulation, areas that are typically the target for commonly prescribed medication. And so we wondered if we could not affect this neuronal signaling by changing the light stimulation and therefore modulating the activity of these pain areas. So how did he do that? We changed the stimulation. So we increased a specific wavelength of light because all the photoreceptors are specific from different wavelengths. And so this way, we modulate the activity of these photoreceptors and we change neuronal signaling. So of course, it will change the way we see because we are actually affecting the visual pathway. But what we found out is that we're also affecting these pain modulation areas. And so the whole concept here is to modulate brain activity through the visual system in order to reprogram the brain through the eye to reduce pain sensitivity. In a way, I try to make this parallel. Usually we develop a compound to act on a receptor. Here, we're still affecting receptors, except that our compound is a photon. And so about this photoneuromodulation project, everything started in 2017 and 2018, where two teams, so one in Tucson here in the Department of Pharmacology, and another one in Boston, where they used a wavelength at 525 nanometer, so it's in the green spectrum, to modulate the activity of the neurons in the retina and to provide pain relief. And here on the right, you have an example of this preclinical proof of concept where they exposed rats each day to green light. So over 5 days, it was 8 hours a day. And you can see here their sensory to thermal stimulation. And you can see that their sensory threshold increases over time. And what's very interesting is that it's still efficacious even after we stop green light exposure. So it seems that there is something that is happening long term in the brain. And following this preclinical proof of concept, a few clinical trials, because yes, it's cool. We observe that in animals, but what about humans? So, a few clinical trials, one done in migraine patients, where the patients were exposed to green light for 10 weeks, 1 to 2 hours a day. And at the end of the 10 weeks, they observed around 60% reduction in headache frequency. Another trial, this time with fibromyalgia patients, same 1 to 2 hours a day over 10 weeks, and at the end of the 10 weeks, patients experience about 40% reduction in global pain score. But what's interesting between these two trials is for the migraine patients, we started to see benefits after 2 weeks of exposure. With fibromyalgia patients, we started to see benefits 4 to 5 days after the beginning of the exposure, showing here that we can have a very different timeline depending on the type of chronic pain. And then there was also this study from a Japanese team. They, I'm mentioning it because they chose a different paradigm. They just exposed the patient 15 minutes before doing a procedure, so a peripheral intravenous cannulation. And just with these 15 minutes of exposure, they were able to decrease the pain by 62%. So you see, depending on the condition, we can have a very different time course. And so, of course, after these clinical trials, it raised huge interest in the therapy, so in the whole community. And multiple teams, so all over the world, worked to try to understand how this was working. And I don't know if everybody on Zoom is a pain specialist or is familiar with pain, so I'm just going to describe a bit quickly how pain is processed in our body. So we have two main systems. One that is called the ascending pain pathway. So when you have an injury, it will stimulate peripheral neurons, so which are typically they're summarized in the GRG. Then it will be transmitted to the spinal cord and go all the way up to the thalamus and the somatosensory cortex. It's the primary input for pain. If you're pinching yourself, you feel it. That's how it works. Then we have the descending pain pathway, which involves somatosensory areas, also, even if it's not mentioned here, but also the thalamus and the PAG, so the periaqueductal gray, which can be considered as the first door of this descending pathway. Also the RVM, the rostral ventromedial medulla. And all this pathway will connect to the spinal cord and will modulate the primary transmission of pain. So it can either increase it, also reduce it. And most of the studies have focused on different brain pathways, so involving the V2M, which is the visual areas, but also the ACC, the anterior cingulate cortex, the PAG here. Another study focused on demonstrated the involvement of the RVM, and then other teams focused more on the CSF and neuroinflammation, on the effect in the CSF and neuroinflammation. And from all this work, I think we can gather three main mechanisms. So first, green light modulate the activity of the endogenous opioid system. And by that, I mean that it was shown to increase the release of proenkephalin and beta-endorphin in the CSF. Also that it required the expression of mu opioid receptor and delta opioid receptor in the spinal cord. And finally, that the activity of encephalinergic neurons, so releasing enkephalins, was increased in the brain. Then also a lot of studies on glutamatergic transmission, because glutamate is the main neurotransmitter in the brain. And so some of the teams focused on how green light modulated the activity of these glutamatergic neurons, especially between the V2M, the ACC, also showing that in the ACC, it was reducing the activity of glutamatergic neurons projecting to the PAG. And finally, also in the spinal cord, showing that the expression of glutamatergic receptors was reduced. So lots of teams focused on that. Finally, a few teams looked, actually it's not, now it's more teams than that, on neuroinflammation, showing that green light decreased the release of pro-inflammatory cytokine, but also microglial reactivity, so in these specific brain regions. And what's interesting here is that this effect on the endogenous opioid system, the glutamatergic system, neuroinflammation, they seem to all focus, to all converge on the descending pain pathway. So with the PAG, the RVM, and spinal cord. As you can see here, visual areas, so such as the VLGN, the IGL, the V2M, so projecting to the ACC, and everything converge on the PAG. So in the lab, it's perfect. Pain, it was all characterized from the eye, the effect of green light from the eye to the PAG. But then we need to go to the spinal cord. So in our lab, we first try to understand how the descending pain pathway, so with the PAG, the RVM, and the spinal cord, was involved. And we looked first at the connection between the RVM and the spinal cord, which in anatomically, so this connection between RVM and spinal cord is represented by the dorsolateral funiculus. So most of the projection from the RVM to the spinal cord will go through the dorsolateral funiculus. So how can we confirm that green light requires descending modulation? Well, we cut this dorsolateral funiculus. And that's what we did in a rat model. So with bilateral lesions of the DLF, so DLF dorsolateral funiculus, and then we exposed the rats for 6 days to green light, to this 525 nanometer wavelength. And what we observe here, so in our control conditions, so sham, the DLF is working, not cut. When we expose the rats to white light, there are no changes in their thermal sensory thresholds. When we expose the rats to green light, we saw increased thermal sensory thresholds, so following 6 days of exposure, so in our controls. Now let's look at the DLF rats. So with white light, we do not see any differences in the sensory thresholds, and it's the same after exposing the rats to green light. So by doing these bilateral lesions of the DLF, we completely block the thermal antinociceptive effect of green light. So here, confirming the involvement of the descending pain pathway. Another result that was important, and I just mentioned it in the beginning, is the effect on endogenous opioids. So in the CSF, where we observed it was four days after exposure to green light, an increase in beta endorphin levels and proenkephalin levels, which are strong. So these two endogenous opioids are strongly involved in pain relief. So we are kind of, right now, we're at this crossroad with, on the one hand, the descending pathway, and on the other side, the endogenous opioid. So we're wondering what was happening to this endogenous opioid system in the RVM. And to look at that, we used naltrexone. So naltrexone is a blocker of mu opioid receptor, kappa opioid receptor, and delta opioid receptor. Basically, it blocks opioid receptors. And we developed a chronic pain model here with GP120 injections. So you can see that the rats developed a strong hypersensitivity. So mechanical, it was tested with Van Fry. So strong mechanical hypersensitivity. Then we expose them to green light. We see a reversal compared to white light, both in males and females, a reversal. But then we inject naltrexone, and we completely abolished the effect of green light on mechanical antinociception. So here we're confirming that the endogenous opioid system in the RVM specifically is required. But you all know research, and that sometimes it doesn't go the way you expect. So for thermal sensitivity, it was quite different. We did not see any effect of naltrexone, meaning that even after naltrexone injection, it was really puzzling for these results. We did not observe any effect on green light antinociception. So the RVM is a very complex structure. Lots of different cells. We have on cells in the RVM that will facilitate pain, and a lot of different subtypes of on cells. We also have off cells, which will actually inhibit pain when they're active. So we tried to understand if this could be due to a specific subtype of cells. And we're very lucky because we found actually Kevin Cheng found this paper. He was the PhD student working on the project. From Amaury François, published in Neuron in 2017, where they identified VGAT expressing cells, so GABAergic neurons, projecting to the spinal cord, and that were on cells, but they were only facilitating mechanical nociception. So we wondered if these cells, if these GABAergic neurons in the RVM could be involved in green light anti-nociception. So how did we check that? Well, thanks to a collaboration with the Mutal Lab, we're able to do a CRISPR approach. So the Mutal Lab, who's now in St. Louis, I know some of you know Oba. And so we did a CRISPR knockdown of both mu opioid receptor and delta opioid receptor, but in VGAT Cre rat with a Cre-dependent plasmid, so a DIO plasmid. So basically, the gRNA targeting both mu and delta opioid receptor is expressed only in these GABAergic neurons in the RVM. And here, again, so GP120 model, strong hypersensitivity, and when we check the sensitivity to thermal noxious stimuli, there was no change with the knockdown. But when we knock down mu opioid receptor and delta opioid receptor in these GABAergic neurons, we saw a nice effect on the mechanical sensitivity. So blocking the effect of green light, confirming here that these GABAergic neurons in the RVM were involved in green light nociception. And that's why we were only able to observe a mechanical effect. So in summary, so far, we've shown that the DLF, so the descending pain pathway, is required for green light anti-nociception. And we've identified one subtype of neurons, so one subpopulation of neurons of on cells, which are expressing both mu opioid receptor and VGAT receptors that are involved in the mechanical anti-nociceptive effect of green light. But there are a lot of different cells, different on cells in the RVM. And so we focused on the VGAT expressing here. There are also NK1 receptor expressing cells. So what about this other population? Is it also involved? And then to analyze the potential involvement of this second population, we use the same approach. So with a Cre-dependent knockdown through CRISPR. So here we just had a different strain of rats, so the TARCA1 Cre rats. So it's a TARCA1 is the promoter for NK1 receptor. So only the cell expressing NK1 receptor are expressing Cre, and then with a DIO targeting mu opioid receptor. And here, so in our control, we can see a beautiful effect of green light. So the model here wasn't GP120, it's the post-surgery model. So we have a nice effect of green light compared to a white light condition, and then a partial reversal of the effect of green light. So following the deletion of mu opioid receptor in these NK1 receptor expressing cells, neurons in the RVM. So to confirm their involvement, we looked a bit at a marker of neuronal activity, so FOSB, specifically in these mu NK1 expressing neurons. So just for people who are working with mu opioid receptor and doing IHC, you may be aware that mu opioid receptors antibody, they are not very good. So I would definitely go for RNA-scope, and you can couple that to a FOSB IHC if you want to look at the activity, because you can couple RNA-scope, so RNA levels, to an IHC. And so this way you have the mRNA to identify the cells, and then the IHC to quantify the protein. And what we've seen here is following green light exposure, we had a decreased expression of FOSB, so of this marker of neuronal activity. So specifically in the RVM in these cells, so confirming that we're decreasing with green light the activity of these on cells. But these results were obtained in males. And when we look at females, well, the results are very different. Actually, we did not see, we saw compared to the injury model, we saw an increase in on-cell activity. So this was a bit puzzling to us, but we do see differences in post-surgical model between males and females, and it's much harder to observe anti-nociception in the females, which is specific from post-surgery, post-operative pain. In headaches model, it's different. So, but at least we have one first way to explain the sex differences. So here in our little summary, we have the involvement of the descending pain pathway, identifying one population involved in mechanical anti-inception and a second population that is identified to explain sex differences. So it's cool, working a bit more, but we still have a lot of different subpopulation to evaluate. But one thing that we do in our lab a lot is switching between preclinical, clinical, preclinical, clinical. Why? Because at first we have a preclinical proof of concept. It was the 2017 paper where the rats were post to green light. Then we confirm that in a clinical trial with fibromyalgia and migraine patients. But then we want to go back in the preclinical study to understand the mechanism, which is what I just presented on the involvement of the descending pain pathway. And then we go back to humans to evaluate if it's the same, if the descending pain pathway, if green light modulates the activity of the descending pain pathway. But in humans, it's a bit trickier because, I mean, aside of chronic pain, people are usually healthy, so they are not really willing to give a piece of their spinal cord or their RVM. So how do we check the effect, the activity of this descending pain pathway? We're using quantitative sensory testing, and more especially the condition pain modulation paradigm. So condition pain modulation relates a bit to the concept of pain inhibits pain. Uh, let's imagine you have low back pain, it's lingering, it's this constant feeling in your back, and you're just walking and you hit your little toe on a furniture or on a door. What's going to happen? You're going to forget about the pain in the back and you're going to focus on the pain on your toe. And this is due to the descending pain pathway. So we try to reproduce this concept in a lab setting. And what we're going to do is we're going to measure sensory thresholds, so both mechanical and thermal at a baseline. And then we're going to measure them again, but in the presence of a conditioned stimulus, which here was an ice water bath, so at 10 degrees Celsius. Because at 10 degrees Celsius, I can assure you, you can try it. Put your hand in the water for 30 seconds, it will be really painful. And so in the majority of patients, what we will observe is increased sensory threshold on the other arm. They will be less sensitive to noxious stimuli. And so by measuring the delta between the CPM measurement and the baseline measurement, we can check the activity of this descending pain pathway. And so we did a quick clinical trial with healthy volunteers. So starting from here, if I mention patients, it's a mistake on my side. Please, it's only healthy volunteers. And so we exposed the healthy volunteers to either white light, green light, or purple light, measure the baseline sensory threshold, and then their sensory threshold during CPM. And we basically plot the distribution of patients. And when it's negative, it means that during CPM, patients were less sensitive to painful stimuli. So there was a pain inhibition. And what we observe is about 70% of the patients will experience pain inhibition, and around 30% of the patient will actually experience hyperalgesia. And I think this is also a very important concept because whenever someone is describing CPM and pain inhibits pain, it's always pain inhibits pain. No, everybody is different. That's why everybody responds differently to a treatment. So for some people, they will be hyperalgesic, but for the majority, they will experience pain inhibition. And one point that is interesting, in the beginning of the presentation, I said that we tried green light with fibromyalgia. So fibromyalgia is a very complicated chronic pain affection. And if you measure CPM in these patients, you will see that it's more about 70% to 50% of the patients that are experiencing pain facilitation. So this shows that in fibromyalgia, there is a strong alteration of the descending pain pathway, and it will actually stimulate, facilitate the pain. So maybe that's why we had a very nice effect of green light in our fibromyalgia cohort. But now let's see a bit the effects of light in our healthy volunteer. So here you have the distribution of patients before white light, so 70%, 30%, and we see after white lights, so it's around 75%, 25%, so there are no big changes in the proportion of patients. And when you do a linear regression, you see there are no significant results, no significant differences. Then it's the same for purple light. We do not have any significant difference between before and after exposure. But then with green light, you can actually see it on the distribution of patients. Patients so went from 27% experiencing hyperalgesia to only 11.5%. And so if you check the linear regression, there is a real shift here showing that green light increases the net inhibition from the descending pain pathway. But once again, so here we are very happy. This can explain why we have beautiful results in fibromyalgia. But pain pathway is not only mechanical. There is also a thermal component. Boom, thermal, no effect. Once again, I think measuring thermal pain is much harder than mechanical. So here with white light, we did not observe any effect with the linear regression. Same with purple light and same with green light. So green light did not affect thermal CPM. But CPM and the activity of the descending pain pathway is just a mechanism. It's not the ultimate goal. What we really want to see is that if green light can actually change the thresholds in these patients, in these healthy volunteers. And so we measured the sensory thresholds. And so here you have the percentage of the initial stimulation, so before exposure, on the initial, threshold before exposure. So 100%, there was no difference between pre-exposure and post-exposure. For white light, purple light, same, no differences. But here we're able to increase mechanical sensory threshold just after an hour and a half exposure in healthy volunteers. So this result is actually very important because you can give NSAIDs, ibuprofen or acetaminophen to a healthy volunteer. You won't see that. You will see that actually with opioids, but this is a very strong effect. Once again, we did not observe it with thermal. But I keep talking about the descending pain pathway, and we only see mechanical effects. So what about the ascending pain pathway? Because in preclinical model, we clearly see an effect on both mechanical and thermal pain. So could the effect on thermal pain could be due to an effect to a modulation of the ascending pain pathway? And to measure the ascending pain pathway in patients, it's the same. We cannot collect DRGs or the dorsal horn in the spinal cord. So how do we do that? Well, we use the concept of temporal summation. So temporal summation is a characteristic of C fibers. So C fibers are neurons which goes from the body to the GRG to the spinal cord, and they relay basically pain stimuli. And so they are also characterized by this temporal summation concept. What is it? If you pinch yourself once, you will maybe rate that pain on a 0 to 10 scale around 1. Now, pinch yourself sequentially 10 times on the same spot. I can assure you that the 10th stimulation, the last one, will be much more painful than the inertial one. And so this results from the activity of the C fibers. So this is a presynaptic, so before the spinal cord, this is a peripheral effect on the ascending pain pathway. And so we measured temporal summation in these healthy volunteers after exposing them to white light, purple light, and you can see here the mechanical results, pre and post, no effect of white light, pre and post, no effect of purple light, and here we decreased temporal summation following green light exposure, showing that we are actually also modulating the ascending pain pathway. And once again, no effect on thermal. But as I mentioned, we do see an effect on thermal sensitivity in our preclinical models of chronic pain and postoperative pain. So we tried to dig a bit deeper into the evaluation. And as I mentioned, for temporal summation, we measure a sequence of stimulation. And so here, it's only thermal results. You have the 10 stimuli, so the sequence of the 10 stimuli, which are done approximately once every second, with the pain ratings here. And you can see at the beginning, it increases a bit, so we can see it a bit everywhere. So this could be considered temporal summation, but then it decreases. And this is typical from thermal stimulation. We call that temporal summation, but it's not temporal summation, it's here habituation. It's the same. Think about when you go under the shower and the water is very warm. At first, it can be a bit painful, but then you will get used to it. Up to a point, it can even be comfortable. So it's habituation. Very common to see, not with a mechanical stimulation, but with thermal one. And so we can see here, so pre-exposure, no differences between all our groups, but post-exposure, there was a slight effect of green light, where habituation was increased. So we finally identify an effect on thermal nociception with this temporal summation. So in summary, on the animal side, the preclinical studies, we've identified that the projections from the RVM to the spinal cord are required for the green light anti-nociception, that the opioid receptors, so mu and delta, are also necessary in different subtypes of cells, such as GABAergic neurons or NK1 NK1 receptor expressing neurons, which are mostly glutamatergic. And so these are required for anti-nociception. On the human side, we demonstrated that green light modulates the activity of the descending pain pathway. With on CPM, most of the effects, so actually all of the effects were on mechanical CPM, but for temporal summation, the main effects we observed was mechanical and a slighter, smaller effect on thermal. And in the end, green light increases the net inhibition of this descending pain pathway to increase mechanical sensory threshold. And so, as of right now, we're trying to understand a bit more in preclinical studies this descending pain pathway. We're looking at the connection. I mentioned to you at the beginning that the main first door of the descending pain pathway was the PAG, and so we're looking at the connection between the PAG, the RVM, and the TNC. So the TNC, which is a part of the spinal cord right after the medulla, receiving all the projection from the trigeminal ganglia. So strongly involved in headaches. So we're using a headache model for that. And so we should have more insights into this pathway later in the year. And so as a last slide, I really want to emphasize all the work from all the teams all over the world, because right now, multiple clinical trials have been done. So in migraine patient, fibromyalgia patient, so we did one on migraine, another team reproduced that on migraine, two teams did on fibromyalgia, a recent study on acute pain, and another recent one on knee osteoarthritis. Lots of preclinical evidence, again, on post-surgical pain, even if it hasn't been published yet. I mean, in human. Neuropathic pain, inflammatory pain, and also one last important point, we have emerging indication, such as anxiety. And why am I mentioning that? Anxiety cannot be isolated from pain. In chronic pain patients, anxiety will be prevalent, and vice versa. So if we can have an approach that can treat both, it would be absolutely tremendous. And one team in Boston, so the Bernstein team, is focusing on the effect of green light over anxiety with very interesting results. So I think that's all for today on my side. So I really want to thank everybody from the lab. So an amazing team. You know most of them, our little furry friends. Also all the collaborators, Frank Perka, Oba Mutal, who designed all our CRISPRs, Trent Henderson, we're working on a headache model with him, Ben Stansfield in Florida, he does all our single-cell RNA-seq evaluation, Harrison Stratton and Amal Patwaran at UT Southwestern, who also did a lot on green light. So I thank everybody, and if you have any question, well, I'm here to answer them.
Thank you so much. I have a question right off the bat. Um, is there any evidence of connectivity from the hypothalamus to the PAG or RVM playing a role in green light benefiting pain?
So not in green light, but it has been shown in migraine that the posterior thalamus is involved. So we haven't checked that. So it was done in human. It's the study by Berstein. So strong involvement of the posterior thalamus and in photophobia in migraine patients. So the activity of the posterior thalamus was strongly decreased under green light.
Okay, it's kind of fuzzy in my mind, but recently I read a paper where they were looking at oxytocinergic projections from the hypothalamus to the RVM, and about 80% of them also expressed dynorphin. And
Hmm.
yeah, yeah. So that's where my head was going. And then I'm pretty sure that the RVM also has big roles in sympathetic control, right? With
Yes.
okay, yeah. So that would be very interesting.
So yes, and but that's one of the challenge because all the projections between the PHE and the RVM and from the thalamus are actually very challenging to study because they are very diverse. There is a strong heterogeneity, and I mean, if you basically if you start working on the PHE or the RVM, you wish you hadn't.
Fair enough. All right, thank you.
Thank you.
I've got a quick question.
Hmm?
So, this is kind of reminding me of red light therapy, and red light therapy seems to be like pretty popular now in like health and wellness spaces. And it's something that people are kind of doing at home by themselves using like masks or like red light rooms. So, I'm wondering in the future, how do you hope people will be able to use green light therapy for their pain management in like a similar way, like at home or in more of a clinical setting?
So both. And first, thank you so much for mentioning that because it will allow me to emphasize that it's completely different. Because for red light therapy, the effect doesn't go through the eye. Here, with green light therapy, we are really focusing on modulating neuronal activity in the eye to modulate brain areas. For red light therapy and the photobiomodulation, basically any effect of light on the body, it won't go through the eye. Actually, if you shine red light in your eye, it will increase pain sensitivity. So you don't want to do that. That's why all these masks that are used, especially for headaches, you always has glasses so that to cover and to have absolutely no stimulation in the eye. So it's a completely different process that could potentially be even complementary. So here with red light therapy, people can use it at home. With green light therapy, so all our patients who are using it at home, and actually give me 1 second because I'm just thinking. Yes, just like this. So it's just LED glasses that are filtering and also emitting green light, and that's what we use in our patient. So yeah, easy to use at home, easy to use outside. You can just wear them actually as sunglasses. Yeah. And if you're curious, we have also our placebo control. I don't know how it's going to look, but our purple ones, which I found are actually much prettier than the green ones.
That's really cool. Thank you so much.
You're very welcome.
I had kind of a question about receptors and maybe like the mu-opioid receptors. If like the green light engages like dominantly these receptors and like they're mechanically like for like the descending pathway that's upregulated by estrogen in women and females, does that I know you're smiling, maybe you get that question a bunch. But like are they more vulnerable to like the descending facilitation like at a baseline in comparison? Like is there like the sex difference?
So there are six differences in descending facilitation and descending inhibition. Actually, CPM will be much stronger in men,
Mm-hmm.
and temporal summation, it's the opposite, will be much stronger in women. And regarding the estrogen, I love this question. Why? Because I mentioned that we observed behavioral differences in postsurgical model between female and male rats.
Mm-hmm.
And so we did ovarectomy in the females because it was much harder to observe antennaception in the females. And actually, we saw a very good rescue of the effect of green light in ovarectomized rats. So
Oh,
meaning that the estrogen are definitely important. And you remember I showed differences in the activity between males and females of NK1 receptor cells.
Yeah.
And these NK1 receptor cells, they strongly expressed ER1 and ER2. So estrogen receptor 1 and 2.
Okay, cool.
So it's very recent, and I really want to dig into that because, yes, definitely estrogen are involved.
And so following up after this, that's really, really cool. That I would love to learn more about how you think about the estrogen effects. But this was just in the rats, and I see that you try and go from, preclinical to clinical. Is there something that we can do in humans to kind of see like versus like maybe postmenopausal to
Exactly.
okay.
The postmenopausal part would be the easiest. But migraine, they often stop after menopause.
Yeah,
So we
yeah,
would
yeah.
have to identify patients that do still express migraine even after menopause. But yeah, checking estrogen level and correlating them to the effect of green light, to the intensity of the therapy would be super interesting.
I'll email you about it. That's cool.
Okay, thank you.
Thank you.
We have a question that someone wrote in the chat.
Oh,
They asked, how long does it take for the green light to start to have a meaningful change in pain? How long does the effect typically last after wearing the glasses?
whew. So how long the effect lasts after wearing the glasses? I wish I was able to answer. I am not. We are currently conducting a trial with the Flynn Foundation in both migraine and fibromyalgia patients to be able to answer this question. So how long it lasts after exposure, I cannot answer. I can tell you what happened to one patient. So please do not conclude only about one patient. It's just an equal one. So she was using the glasses for migraine, and after the clinical trial, she decided to stop. And she was so happy because even a week after stopping, she didn't have any migraine. So she sent us an email saying, that's perfect. I feel like I'm cured. Nope, it came back 1 week after. So at least for this patient, the effect, so after 10 weeks of exposure, lasted at least 2 weeks following the end of the exposure. Patients are still using, so patients even from the 2021 clinical trial are still using the light device. So lots of them, it's very different. Some of them it's once a week. Some of them it's every other day. Some of them it's still every day. So it can be very different depending on the patient. But yes, so for the long-term effect, it's observed in some patients, but they are not cured. Definitely not. And does that answer your question, or did I forget about a part of your question?
Yes, thank you. That's very
Okay,
helpful.
perfect. Thank you so much.
I've seen posters all over North Campus asking, do you want to participate in a
Yeah.
purple light trial? Do you want to participate in a white light trial? I imagine a lot of that's probably you guys. Um, have you found that there's a difference in how people respond based off of which color of light they expect to be therapeutic?
So yes, that's why we exclude every patient who knows about green light therapy. Because yes, the expectation can modulate the effect. There can be a placebo effect, all that. So that's why. And that you mentioned white light and purple light. And yes, that's exactly why we chose to show a picture of purple light and not green light, because we don't want them to expect that it's the treatment.
I do wonder if there would be a difference between patients if you have two who both don't know about green light, but one of them thinks that purple light is the treatment, and the other one thinks, gosh, I know a little bit about research. This is probably the control. I wonder between those two people what difference there might be in how they would respond.
Yeah, it's highly probable that there will be a difference because expectations can strongly modulate pain, definitely. That's why we usually try to do crossover design, so patients are both exposed to green and purple, and actually, so double crossover. Some people will be exposed first to green, then to purple. But yeah, and that's exactly why right now we do not pick white light as a treatment condition, because if you comparing white to green you can expect an effect from green. If you're comparing even white to purple, you can expect an effect of purple. And one thing that I'm really scared about with the purple glasses, I'm not kidding, they look very cute, much better than the green ones, and that's why I'm scared that there will be an effect because of that. So it's a very important component that is hard to test, and the only way is to ensure that people do not expect anything from the treatment. So at first that they haven't heard and that they have no expectation. But there is also another way is to actually to measure the expectability of the treatment before doing it. Just one group, green light, you measure the expectability, then you correlate the results, the pain relief they have compared to the expectability levels. And this way you can evaluate a placebo effect. Okay.
I have one more question.
Yes, of course.
So I have zero education in vision. I don't know anything
Mhm.
about it. Are there types of blindness where the photoreceptor would be intact even though the person does not perceive vision or see per se, and they could still have an analgesic response?
Yes, so regarding blindness, whether color blindness or just regular blindness, it really depends on the area that are affected. Because if it's your retina that is affected, it will be completely different compared to if it's the optical nerve or if it's even some different brain areas. So all the effect can be different. One thing we were lucky, we had one patient, a colorblind patient, but they had a shift in their photoreceptors, meaning that they did not have any photoreceptors to green light. And this was a migraine patient, and they were still able to experience pain relief, even if they did not know the color was green. So they could not actually decipher the control from the treatment, which was perfect control for us. And that's why our main hypothesis is that it doesn't go in humans, that it doesn't go through the cones, but through the iPRGCs. So intrinsically photosensitive retinal ganglionary cells, which are actually conserved between rodents and humans, because even the visual system is different between rodents and humans, but not on the iPRGC level. So that's the hypothesis, because this patient had perfectly functional iPRGCs.
That's really interesting. Thank you.
You're very welcome.
All right. Does anyone else have any more questions before we wrap up? All right. Well, thank you so much. That was really interesting.
No,
We appreciate your
thank you.
time.
It was very cool. No, no, I really enjoyed. So thank you so
Awesome.
much, and I wish everybody a wonderful evening.
All right. Bye, everyone.
Thank you. Bye bye.
Thanks.